Hello again, everybody, and welcome back to week 3. This is another online learning module, and this week we will be focusing on looking at various birthing traditions from around the world and what it's like to have a baby here in Australia. I'd like to start by discussing a few, terms or terminology to get us started when we're talking about culturally sensitive practice. There's a quote here from a researcher named Wilson. I'll just read this out for you. Recognizing the need to understand women of diverse cultures rather than requiring them to assimilate is pivotal to providing culturally competent care. Cultural competence begins with an awareness that cultural differences and similarities exist within and between ethnic groups, also different sexual orientation, socioeconomic, geographic, and religious backgrounds. And then this other quote here from a couple of other researchers state, cultural competence cannot be achieved simply through gaining knowledge. Encounters must occur. The best teacher is first-hand experience with a culture, if not immersion in it. So I'm sure these are terms that you've probably come across before, things like culturally appropriate care, cultural competency, although maybe one that you've perhaps not come across so frequently is cultural humility. And although that's actually not sort of listed here in these quotes, I think a really good way to think about the difference between cultural competence, which is something we do refer to quite frequently, particularly in healthcare, versus cultural humility is they're actually quite different concepts. So the idea of cultural competence almost implies that we need to master other people's cultures, whereas cultural humility is more about understanding that it is a continuous journey of learning, a little bit more perhaps what that second quote sort of states, that the best teacher is that first experience with a culture. It's about learning from others, immersing yourself in other people's cultures and traditions. Also, we need to be really mindful of the fact that we can't sort of group people together in these really sort of large, homogenous kind of, sort of cultural isms, like all so-and-so people or all people from this country do this, all black people do this. We really have to be extremely careful not to do that. As that first quote says, there are cultural differences and similarities that exist both, between ethnic groups, but within them as well. And so I think as doulas, as birth workers, we should really be striving towards is cultural humility rather than cultural competence. I hope that makes sense, and I hope that's a little bit of food for thought for you.
My name's Jacqueline Boyle. I'm an Associate Professor of Women's Public Health and Health Equity at Monash Centre for Health Research and Implementation at Monash University. I'm also an obstetrician gynaecologist. A large proportion of our population is comprised of migrant and refugee women now. We know that in some areas their health outcomes are worse, that our health systems are different to what they're used to, so they're not quite sure how to access them. It's sometimes difficult because of socioeconomic determinants of health for them to know how to actually be able to access them even if they are there. It's also important that they feel confident and comfortable going to a health service, so it's important that it's a welcoming environment that is culture responsive. For example, we have women who come from countries who either have never had cervical screening and so don't understand the need for it, or women who have screening yearly by a gynaecologist, so not even a general practitioner. So it's really being aware of where women are coming from and what their understandings are. That it's important for us to be aware of women who may be at increased risk. So for example, in pregnancy, which groups of women are going to be at increased risk of getting diabetes in pregnancy, for example. And then some women who experience difficulty both in numeracy and also reading literacy. So if, for example, they end up using insulin, even the numbers of dialing up their insulin can be challenging at times. And for women, for example, who have come from somewhere where they've never had ultrasounds in pregnancy and they're actually a bit scared and worried about why we're doing this sometimes, or certainly if we're doing more than one because we think that they need increased surveillance, they'll be quite concerned. And if you don't explain these things properly, if you don't use an interpreter, then they're more likely to not turn up for what you've ordered, and then they get labelled as a didn't attend or didn't come, whereas in fact it's more around the fact that they haven't understood why we're asking them to do something. Really important to ensure that their voices are heard and that their views are incorporated across health services, health research and health policy. Everyone needs to be looking at doing that quite broadly. All research institutes, health services need to really think about how they can incorporate those voices in a really meaningful and strategic way. The work of the partnership is important because there are such great needs for migrant and refugee women's health, around health literacy, around access to health, around receiving culturally appropriate care and culturally responsive care. And I think if we act as individual entities, then it's very hard to have impact. So I think that this collective really enables us to have a cohesive voice and to hopefully impact on practice and policy. So it's really brought together some great ideas because we've got representatives from settlement services, community services, from medical, nursing, specialty, primary healthcare. So we've really got a great network of people that are working together. We've really had a fantastic reach right across Australia. So we get to hear from many voices, but it also means that we can disseminate what we do very broadly. So I think there's many facets that have really worked together to make this partnership a really fantastic initiative.
Well, I hope you had a chance to watch the two videos in this presentation. The first one was from the Migrant and Refugee Women's Health Partnership, talking about culturally responsive health services. And the second video came from the Raising Children Network, and that video was you heard from some health professionals and some parents who talked about the support for new birthing mothers. And just as a sort of FYI, the Raising Children's Network is a really good resource for you. There'll be a link to it at the end of the this PowerPoint. You can click on it and have a look. There's lots of really good resources for new families, including information obviously on just in general on health, obviously pregnancy, birth, early postpartum, support services for parents, etc. Lots of really good videos as well, similar to the one you've just seen, so quite short. And also many of the resources on this site are also available in multiple languages. So it is a really good sort of site just to maybe bookmark and use maybe from time to time with resources that you might want to send to future clients. Okay, so we're going to move on now and talk about the experience that some of your future clients will obviously go through once they've had a baby. So in the next slide, what we're going to do is actually go in detail and cover through that process of what it is like to go home with a new baby and sort of the steps that that new parents will be going through. Have a look at the next slide and I'll take you through that. Okay, so I'm going to walk you through what people will typically experience from birth in the first few days, if you like, following the birth and that sort of transition home. This is sort of, I guess, like a high-level overview. We will, of course, in later sessions actually go through, the birth in great detail, all of the stages of labour, including sort of that early postpartum. So this is, as I said, just a sort of high-level overview that we will sort of dig into a little bit more deeply in other sessions. So we're just going to follow along from the left to the right of the screen. Provided that mum has had a really straightforward, uncomplicated birth, essentially the baby is put skin to skin with mum straight away. Woman's healthcare team, her midwives, usually will do some preliminary checks and make sure baby is well. Eventually the umbilical cord will be cut, and mum and baby should hopefully have really uninterrupted skin to skin for at least an hour, and hopefully longer than that. Obviously many things depend on how long she can remain just skin to skin in the birth suite with baby. More often than not, obviously if it's a very, very busy day or night in the birthing unit, there may be a need to sort of move the family through to postnatal, sooner rather than later. But one would hope for at least an hour of uninterrupted, as I said, skin to skin, to allow mum and baby to bond, to allow baby to go through the sort of normal instinctive behaviours of a newborn, again, something that we're going to cover later on in the course, and hopefully for babies at the sort of towards the end of this process to self-attach to mum's breast and to start feeding. In a more complicated birth, obviously something such as a cesarean birth, it's a little bit different. There is obviously more follow-up, there's more time in recovery, there may be some separation of mum and baby, or mum and then baby and partner. Often if baby is well, the partner will be with baby while mum is in recovery. Again, we will be talking in detail about cesarean section. And as for the doula, it really depends on the hospital and what's going on at that particular moment. But certainly there are instances where the doula has been given permission to go to recovery or meet mum in recovery. Actually, during the C-section, if you are the only support person, then you will be permitted to go into the operating theatre to provide that continued emotional support for your client. However, if she has a partner or another close family member that she would prefer to have in the theatre with her, then as a doula you would need to wait outside, usually in the sort of family waiting area. But as I said, there often are instances where the doula gets permission to meet mum in recovery, and then either partner will be with the baby. Again, we will talk about cesarean in more detail, but as I said, just for the point of this particular slide, we can just sort of assume that following a C-section, there often is a sort of a longer period of time before mum will go to the postnatal or maternity ward. In some situations, you may be attending a home birth. In Melbourne, we do have 2 publicly funded home birth programs, one at Joan Kirner, which is Sunshine Hospital in Melbourne's West, and then we also have the Casey Hospital program, which is part of Monash Health out in the eastern suburbs. So it is possible, absolutely, that you may have a Birth for Humankind client who's birthing through the publicly funded home birth programs. If any of you go on to work as a private doula, you very well may have clients who opt for home birth with a private midwife. So in those situations, if your client gives birth at home, then typically midwives will stay with the mum for a few hours after the birth until they are very confident that the mum and baby are well and everybody is healthy and everything is stable. And usually mum and baby are tucked up in bed, with a good meal before they head off. So very different kind of setting. and we will also talk a little bit more about home birth as well during the course. Although realistically, I would say certainly as a doula with Birth for Humankind, overwhelmingly, without question, the births will be hospital births. And even as a private doula, given the fact that, close to 99% of women will have their baby in a hospital, you probably won't attend a huge number of home births, although they are always amazing and I think incredibly valuable experiences as a doula to attend a home birth and support women in a completely different environment and setting to a hospital. So back to this slide here. So following the birth, again, there are differences in terms of the physical recovery from birth, depending on whether it was a really uncomplicated vaginal birth or whether mum is recovering from, say, an instrumental birth, forceps or vacuum, whether she had perineal damage and required suturing following a tear or potentially an episiotomy. And of course cesarean section. So again, there's going to be some differences in her early physical recovery, but in general, some of the really common things that all women will experience will be postpartum bleeding, cramping, swelling, sore breasts, occasionally issues with urinating, with passing a bowel movement. More often than not, they tend to be more fear about, going to urinate, or fear of having a bowel motion, not because of any real damage, but more just a concern about pain, or if they've had stitches or anything like that, they might do some damage, which is very, very unlikely to happen. Also from an emotional perspective, it is really normal for women to go through a really quite wide range of emotions, and I'm not even really going to factor in emotions that are as a result of perhaps a difficult or traumatic birth experience. And again, birth trauma is a really important topic that we will spend some time on later in this course. I'm talking more about the normal hormonal changes that more or less everybody will experience, usually around that sort of day 3, day 4 after the birth. Very, very typically that is when people experience a really significant shift in their hormones. Up until that point, their body has been predominantly producing very, very high levels of pregnancy hormones, and obviously birthing hormones, and once the body truly recognizes that you're not pregnant anymore, those pregnancy and birth hormones take a really deep dive, and in their place usually lactation hormones are the ones that really start to rise. And so with a sort of significant hormonal shift, it's very normal for people to sort of feel really quite overwhelmed and emotional in those early days after the birth. Sometimes we talk about the baby blues, and that's very typically exactly what people are going through. As I said, lactation hormones are really becoming the dominant hormone in a woman's body, and breastfeeding is obviously is the natural sort of continuation physiologically of the process from pregnancy, birth, and lactation. In terms of the support that your client will have access to, then she certainly will have as much support as she needs from the hospital. The hospital will have both lactation consultants on staff as well as a breastfeeding clinic that she will be able to attend when as often as she wants to, for weighing her baby, for getting obviously lactation advice and support from midwives and lactation consultants. Lactation advice is also available in the home, but usually this is via a private lactation consultant, which is usually an out-of-pocket fee, and therefore not everybody has access to. So again, with breastfeeding, it's a very big topic, and we will devote an entire module and session to breastfeeding later on in the course. Following on from that, we will definitely be talking to our clients about the importance of safe infant sleeping. They will also receive information and support from the hospital, from the midwife, and when they get home, from the maternal and child health nurse. One thing that is important to just be mindful of, and that is the topic of bed sharing or co-sleeping. In which case this is not information that they will get really any practical support or assistance with through the sort of channels through the hospital, or, as I said, through the maternal child health nurse, and that's because essentially fundamentally they don't support those practices, and they're not therefore going to be giving advice around it. What they will probably do is actually strongly advise against it, and that could be problematic, especially given that it may be a cultural norm for your client's family. We will explore safe sleeping, again later in the course. But just be mindful of that fact that, again, it may be the cultural norm for your client to have baby in the bed and to co-sleep, and they may be very surprised to learn that they're not going to have any support around that from their healthcare providers. A couple of other things to just quickly look at on this slide. When your family leave the hospital, they will leave with some very important documents that it's really, really important that they don't lose. Getting copies is incredibly difficult to get a hold of. Essentially, these are documents they need to complete in order to register the birth of their baby, and then subsequently apply for things like parenting support through Centrelink, and other perhaps community-based support services through Centrelink, through Medicare, etc. Occasionally you may have clients who may need assistance with filling in forms. That's something I think that Kath and Christine from Birth for Humankind will certainly address in the induction training in more detail as part of a broader discussion around translation services and the role that you play as a doula in that. In many cases, there is somebody in the family or a close family friend that can assist them with filling in those forms, and that's what we generally would recommend that they do. So the main thing is just to reiterate to them that these are very, very important documents. They do need to look after them safely, and they do need to return them to the appropriate services. And then finally here, we just want to, let our clients know, and again, this sort of information, ideally, we're going to be discussing and presenting to clients in the antenatal appointments, and helping them to understand what they're likely to experience, so that we're not sort of telling them at the time. They will hopefully know this and expect that this is going to happen. So once they've got home, usually within 24 hours, they will have a home visit from a midwife from the hospital where they gave birth. It's very unlikely to be the actual midwife who was there at the birth, but it will, it will be a midwife who will come and sort of do a fairly sort of basic checklist of ensuring that everything is okay and that mum is recovering well and the baby is well, etc. And that visit is then followed up, probably within a week or two, from the maternal child health nurse, which is operated by local councils, not the hospital, but the hospital will organise that initial visit. Beyond that initial home visit by the maternal child health nurse, future visits are usually done at your local or at the mother's local maternal child health centre, of which there's usually several in her council area, and she is able to access any of the centres that she likes. It doesn't have to be the one geographically closest to her. So that's, again, very quick overview. We will definitely break this down in a number of future sessions where we'll go into a lot more detail about labour and birth, about cesarean, about instrumental birth, postpartum, issues, breastfeeding, etc., etc. But I hope this has been helpful just in giving you a very sort of broad overview of very typically what your families will experience in those first few days. One of the things that we covered a little bit in last week's session was the topic of health inequity, and how the fact that some people receive care that is that's not equitable compared to others. And in context of the sort of topic that we're covering today, this is a really interesting study that I came across, and essentially what it was looking to find out was the differences between the experience for women who were immigrants to Australia compared to Australian-born women in terms of, their birthing experiences and those early postnatal experiences. So this was a study done through La Trobe University, in 2010. It's a little while ago, but I would, I'd put money on the fact that I don't think an awful lot has changed, even in the sort of last 12 years. So as I said, this study compared the post-childbirth experiences of Australian-born and immigrant mothers from non-English speaking countries. So that was an important aspect of immigrant mothers. They weren't looking at people who'd immigrated from countries like the United States or Canada or the UK. And the results are really interesting, and perhaps not all that surprising. So immigrant women were more likely than Australian-born women to be breastfeeding at 6 months and were equally confident in caring for their baby and talking to health providers. So that was positive, and that's a really positive finding. And they didn't find differences in anxiety or relationship problems with partners. But there were some differences. So compared to Australian-born women, immigrant mothers were less proficient in English and did have a higher prevalence of depression. So quite a marked difference with that. They were more likely to report wanting more practical and emotional support, and were more likely to have no time out from baby care, as well as more likely to report feeling lonely and isolated. So actually the next slide, we're going to look a little bit more at that and just sort of summarize some of those findings. But if you're interested to actually read that study, there is a link to it at the end of this presentation, so you can click on that and actually have a read yourself. So just to summarize the key findings from that study that we just looked at in the previous slide. So mothers from immigrant backgrounds and specifically non-English speaking immigrant backgrounds are more likely to experience postnatal anxiety and depression. There is a greater need for practical and emotional support. They're more likely to report not having a break from caring for the baby and very likely other young children at home, and are more likely to report feeling lonely and isolated. As a doula, as a birth doula, we do meet with our clients a couple of times after the birth, but certainly one of the services that Birth for Humankind are now also able to offer is more extended postnatal support for women who have been identified as really requiring that additional support in those early weeks postpartum. We as doulas also, I think it's really important that we have a very broad knowledge of support services in and around Melbourne, particularly for immigrant families and families from non-English speaking backgrounds, where we can refer, that we can recommend, that they contact and that they engage with, particularly for these sort of things, these issues around the need for support, for connection from other families, from people who really understand them, understand perhaps some of their circumstances, that can communicate with them in language. etc. And so that will be actually one of the sort of larger outcomes, if you like, from this course, is that we would love each of you to really put together a very comprehensive list of of support services, of resources. Again, the more specific and appropriate they are for families from immigrant backgrounds, the better, because of the nature of the clients that Birth for Humankind do typically support. So, as I said, that study, if you are interested, is available, and you can click on the link at the end of the presentation. So, as I mentioned just on the previous slide, as a doula supporting our clients, we can really provide them with a wealth of information around some of the relevant postnatal support services that they can access. And just as I just want to ensure that everybody is familiar with the term CALD, or CALD. That stands for culturally and linguistically diverse families. And again, that they are sort of certainly a very large percentage of the families that Birth for Humankind support are women who do come from CALD backgrounds. So these are just some of the things that you might want to be thinking about. So obviously there is the local maternal child health centre. Those centres, as I said, are council operated and predominantly are are focused on well baby checks. They provide immunizations, feeding advice, although that can vary according to how good the breastfeeding advice is and how up to date that advice is. Certainly weighing baby, and to a lesser degree there will be some focus on postpartum support for mum, particularly when I'm talking about postnatal mental health. Again, that does vary according to the maternal child health nurse excuse me, and their level of expertise in that field. In terms of breastfeeding and more broadly with infant feeding, support and information, the Australian Breastfeeding Association does provide a really wide variety of excellent information, also in multiple languages, which is again very helpful. Not all their information is available in multiple languages, as in you couldn't go onto the website and just click on it to be all in Arabic or all in simplified Chinese, for example, but certainly they do have a lot of their information sheets. The most important ones are available in multiple languages. The ABA also have a chat line, as in live chat through texting through their app. They have a phone-based support line, which is 24 hours a day. When we have our session later in the course about breastfeeding and infant feeding, we'll talk about this in a little bit more detail. There are culturally based mother and baby groups across Melbourne, often organised by local cultural centres. Again, they may be a little bit harder to find if you are yourself not part of a community group. But certainly it would be really great in terms of your own research to try and find out where these groups are, particularly in the future, if you do have clients who come from a particular background, you say, oh, I know of a really great mother and baby group that meets here, for example. We can talk to our clients about, the importance of having a good family GP, somebody that they really they like, that they trust, that they feel understands them, that provides that culturally sensitive care, for example, and just to talk through with them, with your client, about the process of what to do if their baby gets sick. Who do they call? Where do they go? Etc. And then finally, I think it would be incredibly valuable for you to create a list of services around perinatal mental health, and they could include helplines. Again, particularly if you're aware of services that provide support in languages other than English, in-person support services, etc. So again, that will be part of a larger assignment and requirement of the course to actually compile a really comprehensive support and resource list. So for this week, there are a few sort of small little homework assignments, but just to finish off this week's sort of presentation through the PowerPoint, I'd like you to do a little activity. So I'll explain what I'd like you to do, and then you can sort of just pause the presentation and spend a little bit of time working on this activity. So, spend maybe about 15 minutes or so, obviously longer if you like, but what I'd like you to do is actually to do a little bit of online research and find out what specifically postnatal and family support services are available. If you yourself are a bicultural person, what services are available for your community, and if you don't come from a sort of bicultural background, perhaps you could just look more broadly at what support services there are particularly for families from CALD backgrounds. So some of the areas I'd like you to sort of be looking for in terms of your online research is support around breastfeeding, just generally more broadly practical parenting, newborn care support information, any mother-baby groups, and again, if you can locate mother-baby groups that provide, sort of specific groups for, certain community groups and certain in-language groups would be great. Childcare options as well. There's a huge variety of childcare out there. And again, it can be very overwhelming if you were a sort of relative newcomer to Australia to understanding what childcare exists out there. So, if you can provide a little overview and explanation of those different options, that might be very helpful for a new family. Support for new fathers as well, and again, if you can locate information for fathers, for partners who come from CALD backgrounds, that would be fantastic. Also, very important topic is perinatal mental health. So what are the support services available for people experiencing perinatal anxiety and depression? And again, it might be a combination of some of the more well-known support services like Panda, for example, that have free hotlines, as well as perhaps more community-based services and that in-person support as well, which is very important. Family violence is another area I'd like you to look at. And again, what services and social services are available for families affected by violence and in DV situations. We know, and if you've sort of had any, you have any sort of experience or knowledge around family violence, you'll know that the greatest risk for women is who, in terms of risk of being, experiencing domestic violence is during pregnancy and in early postpartum. So again, that might be very, very helpful to have some of that information available for clients. And then also, I'd love you to please try and do some research around family services for people who identify as LGBTQIA. So yes, there's a very wide range of things. Again, the focus is on postnatal support for these services. Please, upload your findings in Better Impact, and look forward to seeing what you come up with.